So late-stage multiple myeloma is an unmet medical need. We see this from the cohorts of the MAMMOTH cohort, for example, a retrospective cohort of patients with triple-class refractory or even penta-refractory patients with a median overall survival lower than 6 months, or the locomotion studies, for example, showing also in triple-class refractory patients a poor outcome. So it's clearly an unmet medical need, but we had the chance in the past 2 years to have 6 new approved drugs by the FDA and EMA. So this is the anti-BCMA treatment. The first one that got an approval is the Belantamab mafodotin. It was in 2020, both at FDA and EMA. And it's an antibody drug conjugate targeting BCMA and attached to MMAF, a toxin. And the DREAM2 protocol led to approval to the dose of 2.5 milligram per kilogram. So this is one of the first option that we had for these triple-class refractory patients. And then 2 other anti-BCMA therapies were approved later on. IDCell, the first approved CAR T-cell for multiple myeloma, targeting BCMA again, and it was approved in 2021. Based on the KARMA trial, a phase 2, randomizing patients with late-stage multiple myeloma with different doses of the drug, but the dose of 450 million CAR T-cells reinfused was approved with very impressive results, 84% of overall response rate and a median PFS of 12.1 a month. And then the second CAR T-cell approved is the cilta-cel. It was approved earlier this year in 2022. Cilta-cel has an extremely good profile of efficacy with almost 100% of response rate and a median PFS that was not reached at 27 months at the last update with a rate of 55%, still not progressor at that time point. So that's very interesting, and it's truly new options for those patients. And on the top of that, we have small molecules, selinexor, which is an inhibitor of XPO1 based on the STORM study that was approved as well by the FDA and EMA recently, and the melflufen, which is a modified melphalan that just recently got an approval from EMA. There is no approval by the FDA, and that can be useful for some patients, especially the patients who are not exposed previously to alkylating agents. So all those new regimens are useful for those patients. However, we need to keep going with finding new options for those patients because we see that their outcome is sometimes preserved short.